Welcome everyone to Bone Voyage, a podcast dedicated to prevention and raising awareness of musculoskeletal disease. My name is Dr. Kranti Peddada, an orthopedic surgeon, bone and joint health advocate, and your host for this show. Come join me as we embark on this journey to better bone and joint health. Welcome everyone to the final episode in our knee arthritis series. We've discussed several topics until now, including defining arthritis, reviewing the symptoms of knee arthritis, discussing non-operative treatments, explaining total knee replacement surgery and the latest advances in technology and techniques, and finally touching on alternative surgical options for knee arthritis. In this episode, we're going to summarize and connect key points from all these episodes. As always, please keep in mind that everything presented here is purely informational, should not be interpreted as medical advice, and does not create a doctor-patient relationship. Please consult a physician or another qualified healthcare provider with any questions you have regarding a medical condition and before you make any changes in your healthcare behavior. Everything I discuss is strictly the opinion of myself and does not reflect the views or position of any entity I represent. Please reference the episode description for a full disclaimer. With that, let's get right into it. Arthritis is a disease of joint degeneration that generally affects the most flexible joints in our body, called synovial joints. These joints are cushioned by a material called cartilage, which breaks down in this disease. There are many forms of arthritis, but the most common is osteoarthritis, which is age-related joint breakdown. Most people over 65 have at least one joint that's arthritic, and the joint that's most frequently affected is the knee. Risk factors for osteoarthritis include older age, female sex, a family history of osteoarthritis, and obesity. Obesity is an important risk factor because it's the only one that's truly modifiable. The most common symptom of knee osteoarthritis is pain. The pain is most noticeable with activities where you put weight on your legs, such as standing and walking, and is worse the longer you're engaged in the activity, such as walking for 60 minutes versus 10 minutes, and the more impact the activity has on your knees, such as running. The pain progresses with time, usually over the course of months to years, and it's common during this period to have exacerbations or flares of pain that can last days or weeks. Other symptoms include stiffness, a change in the alignment of the knee where it can become bow-legged or knock-kneed, a grinding or crackling sensation in the joint called crepitus, and weakness or instability when walking. Arthritis is diagnosed with an X-ray that can show narrowing of the joint space and bone spurs. When arthritis is advanced, you can see bone-on-bone contact where the thigh bone or femur is literally touching the shin bone or tibia because the cartilage cushioning has completely eroded away. It's important to distinguish arthritis from other common causes of chronic knee pain such as bursitis, tendinitis, IT band syndrome, and meniscus tears. Meniscus tears are diagnosed with an MRI scan. There are lots of ways to treat knee arthritis without surgery. Activity modification is the simplest, which is limiting activities that cause pain, breaking up single long walks into multiple shorter walks during the day, or switching from a consistent running program to riding a bicycle or using an elliptical machine to reduce knee impact are some examples. Another is wearing a knee brace. There are two types of knee braces, a structural brace and a non-structural brace. A structural brace, also referred to as an offloader brace, works best when there is more arthritis in one half of the knee compared to the other. It works by cranking open the space in the arthritic half of the knee so pressure is alleviated in that half of the knee when you walk. While studies do show that they can improve pain and walking distance for some patients, they usually are cumbersome to wear and compliance is low. A non-structural brace, also called a knee sleeve, is made of a neoprene or other elastic material that snugly fits over the knee. While it does not alter knee mechanics like a structural brace does, it's much less bulky and easier to wear. Knee sleeves primarily function by providing compression, warmth, and mild stability to the knee and work well for some people. Medications can also be used for pain relief in knee arthritis. Non-steroidal anti-inflammatory medications or NSAIDs are the most effective. Examples of these are ibuprofen and naproxen. Familiar brand names are Motrin, Advil, and Aleve. Some people should not take NSAIDs, and common reasons include current use of a blood thinner, a history of kidney disease, and a history of gastrointestinal bleed. They may also interact with other medications, so talk to your doctor to make sure it's safe for you to take NSAIDs. Other pain medications, which can be used instead of or in conjunction with oral NSAIDs, include Tylenol and the various over-the-counter topical pain medicines such as lidocaine patches and brands like Salonpas, Biofreeze, Icy Hot, and Voltaren Gel, to name a few. Opioids are not recommended for long-term pain control for arthritis given their addictive potential. Finally, supplements such as glucosamine, chondroitin, and turmeric have unclear benefit in arthritis treatment, with some studies showing they work and others showing no difference. Some non-operative treatments that require more time and effort but can provide longer-lasting pain relief include weight loss for people who are obese and a knee-specific exercise program. Remember that the knee experiences 2 to 5 times your body weight in force, so each pound you lose can have an amplifying effect. Exercise programs can be effective if done consistently for about 6 weeks by strengthening and stretching the muscles around the knee to provide better stability and alleviate stress on the joint. People who continue to be symptomatic despite these treatments may benefit from injections. The most common injection is a cortisone or steroid injection, which helps reduce inflammation in the knee. These injections can be repeated no more often than every 3 months. For people who don't get relief from cortisone injections, hyaluronic acid or gel injections are an alternative covered by most insurance plans. Platelet-rich plasma or PRP injections have gained popularity recently, and some studies have shown they can be effective in alleviating pain. However, these injections are usually not covered by insurance. People with knee arthritis who continue to be symptomatic despite non-operative treatment may benefit from total knee replacement surgery. The criteria for knee replacement surgery are 1. Moderate to severe arthritis evident on imaging, 2. Pain that affects an individual's daily quality of life, and 3. Pain that's primarily due to arthritis. A knee replacement can be better thought of as a knee resurfacing procedure where just the damaged cartilage and bone along the undersurface of the kneecap and at the end of the femur and tibia are removed and replaced with implants. Modern total knee replacement implants have 4 parts: the femoral component, tibial component, plastic spacer, and patellar button. The femoral and tibial components are made of cobalt, chrome, or titanium metal, and the plastic spacer and patellar button are made of polyethylene plastic. The femoral and tibial components, as well as patellar button, can be secured to the bone with polymethyl methacrylate, also known as bone cement, or a special coating that allows bone to grow into it over time. Many patients go home on the same day of surgery thanks to anesthesia nerve blocks, effective pain medication, and good preoperative education and home preparation. Physical therapy is critical after surgery to regain strength and flexibility of the knee. Full recovery can take up to a year, but by 3 months, many patients can return to most activities. The most common complication is stiffness, which can happen 5 to 10% of the time and may necessitate additional procedures or surgery to regain range of motion. Overall, total knee replacement surgery is a successful operation, with 85% of people being satisfied after full recovery. Modern knee replacement implants have good durability, with about 85% lasting 20 years. To maximize longevity of the knee replacement, it's advisable to avoid high-impact activities lifelong. If you look at websites advertising total knee replacement surgery, you'll probably come across robotic technology and minimally invasive approaches. Robotic assistance in total knee replacement surgery has gained popularity recently. These systems provide 3D navigation and a robotic arm to provide better accuracy and precision with implant placement. While some studies suggest improved pain and better range of motion in the early post-operative period, long-term outcomes after full recovery are no different compared to conventional techniques. Minimally invasive approaches usually offer a smaller incision and do not cut the quadriceps tendon when gaining access to the knee during surgery. On average, patients may have slightly less pain and regain their quadriceps strength faster after surgery, but again, long-term outcomes are no different compared to the conventional approach. Aside from total knee replacement surgery, 2 other surgical options exist for patients with knee arthritis. These are called high tibial osteotomy, or HTO, and a partial knee replacement. These surgeries are specifically meant for people who have arthritis confined to one part of the knee. An HTO changes the alignment of the knee joint by creating a wedge in the tibia. The new alignment is meant to offload the part of the knee that's arthritic and increase contact on the side that's healthy. This is a good option for young individuals who'd like to maintain an active lifestyle that might otherwise wear out a knee replacement early. Most of these patients can go 10 years or more without needing a knee replacement. The second option is a partial knee replacement, where only the portion of the knee that's arthritic is replaced and the remainder of the knee is left intact. Partial knee replacements have the advantage of having faster recovery with fewer complications, and patients report better final range of motion and a more natural feeling knee compared to a total knee replacement. However, partial knee replacements wear out faster than total knee replacements, and arthritis can progress in other parts of the knee. Both situations may require another operation to convert to a total knee replacement. One surgery that has not been proven to be of benefit in patients with moderate to severe arthritis is an arthroscopic clean-out and should generally be avoided. With that, I wish everyone bon voyage. This is the conclusion of Season 2. We've had tremendous support and interest. I want to personally thank all of you for listening. See you back for Season 3.
Thank you for tuning in to this episode of Bon Voyage, your journey to better bone and joint health. Please join us on Wednesdays for new episodes. If there are certain topics you would like to listen to, or if you have feedback for the show, please email us at bonvoyagehealth@gmail.com. If you enjoy listening, please follow and subscribe to our podcast. Thank you for all your support.